Hello, everyone, and good morning. My name is Tia Balat, and I am the chair of the programming committee for the 5th annual Black Maternal Health Conference. And it's my pleasure to introduce our next speaker, Dr. Judy Bigby, who has devoted her career to decreasing racial disparities in healthcare and educating physicians regarding care for those with history of substance use. Dr. Bigby served as Secretary of Health and Human Services for Massachusetts from 2007 to 2013, during which time she implemented key aspects of the 2006 Massachusetts Health Care Reform Law. In 2011, President Barack Obama appointed Dr. Bigby to the Advisory Group on Prevention, Health Promotion, and Public Health Council. Today, Dr. Bigby will be having a conversation centered around highlighting the history of racial disparities in women's health. Please welcome me in joining Dr. Judy Bigby.
Thank you so much for that wonderful introduction, and I'm really looking forward to participating in the conference today. I want to thank Dr. Amoto Anukago for organizing this conference for the 5th year in a row, and I'm honored to speak here. I also want to thank, I know you'll be hearing from many public officials, and I want to thank them for their work and their advocacy and their work to strengthen the session. Can we have the slides up now? As you heard, I'm going to speak today about the history of racial disparities in women's health. And if there's one thing I want to leave you with today, it's that poor maternal outcomes are not a pregnant woman's problem. They are the extension of disparities that we see in Black women's health across the entire life cycle. And the root causes include social policy, health policy, racism, and misogyny. However, there's a lot that can happen in the healthcare system to improve women's health, and we should not absolve the healthcare system of its responsibility just because we have all of these very large problems that are external to the healthcare system. Next slide. So I'm going to go through a little background first. Next. On this slide, you can see a picture that I'll describe in just a minute, but I want to point out that the long arm of slavery has an important impact on women's health. We know that legalized enslavement of African men, women, and children resulted in generational trauma that has biological consequences that exist today in women who are still manifesting these issues. And there has not been enough to address this problem in the healthcare system. What you see in the picture to the right is a picture that's supposed to be celebrating a surgeon who perfected surgical techniques on women that were enslaved and were sold to him for the sole purpose of him practicing these techniques. If you look to the left of the picture, along the left side of the curtain, you'll see 2 Black women looking around the side of the curtain, and they must be wondering, what is going to happen to me? They know what has happened to the other woman there who's at the center of the slide, and surely they passed on their mistrust of white doctors to generations to come because of the experience that they saw here. Next slide. I also want to point out that the healthcare system has a long history of both legalized and de facto segregation. In fact, Congress passed a bill in 1945 to expand healthcare resources so that the American healthcare system could expand, and they allowed those funds to be used in segregated hospitals. It wasn't until 1964 that the U.S. Supreme Court struck down the provision in the Hill-Burton Act that allowed funds to be used in segregated hospitals. This is the year that the Civil Rights Act passed, and it also prohibited the use of federal funds for racially segregated institutions. However, the last segregated hospital was not officially desegregated until 1973, so it took almost 10 years for that to happen. And that was not such a long time ago. It was the year that I entered medical school, and I'm not that old. Next slide. One of the other issues that really is a problem in our healthcare system is that we don't have universal access to health, and it's not been embraced as a standard policy in the United States. Many people know about Medicare, which was passed in 1965 by Lyndon Johnson, who as president was embarrassed that there were millions of elderly people without access to medical care. But this system only serves those who paid into the Social Security system, and therefore only some elderly and some disabled are covered. The Medicaid program was also passed in 1965, but it only covered pregnant women through 6 weeks of pregnancy, 6 weeks after the pregnancy ended, some infants and children, and some poor, elderly, and disabled and blind. And not all states had to participate. In fact, the last state to participate was Arizona, which did not have Medicaid until 1982. The Affordable Care Act, developed by President Obama, was passed in 2010, and it expanded Medicaid eligibility so that it could act as an insurance program for adults with incomes below 138% of the poverty level, which is about $24,000 for a family of two. And this provision would allow post-pregnancy coverage. But because the Supreme Court ruled that the federal government could not mandate that states participate in the ACA, some states elected to not participate. And we'll get back to that in a minute. Next slide. So let's move on to look at what some of the consequences of these longstanding issues in the healthcare system are for Black women. Next slide. So this slide tries to summarize the various things that are particularly problematic in the United States for Black women. We know that Black women report that they experience bias and racism in their healthcare encounters, so interpersonal bias and racism. They have less access to behavioral health services, including in the postpartum period when they might have depression and anxiety. They have less access to contraceptive services, but on the other hand, they're more likely to be coerced to use contraceptives as a condition of some social programs. We all know they experience higher rates of unintended pregnancy, of low birth weight babies, and higher infant death rates. Black women have a 22% higher rate of C-section for low-risk pregnancy, which is a very important issue because this often leads to adverse pregnancy outcomes and maternal mortality, which is much higher among Black women. There also is an increased burden of sexually transmitted infections and HIV, and higher breast and cervical cancer deaths, even though Black women have relatively high rates of screening for breast and cervical cancer. A lot of the deaths are due to delayed treatment. There also is a higher rate of cardiovascular disease, and Black women with cardiovascular disease are less likely to receive specialty care. There's more chronic disease prevalence among Black women, including for arthritis and diabetes. And not surprisingly, Black women have a shorter life expectancy than other women. Next slide. So if we think about why is this slide shows the things that contribute to health status, but go to the next slide, please. We can see that these factors, which are inside of the pie chart, are mediated by those that are in the continuous circles outside of the pie chart, and that racism often is what is at the center of the issues that make these factors so important to Black women. So if we look at healthcare, that only contributes to 10% of health status, according to analysis. And we see that things like social and structural entities contribute about 40%. But if we look at the outside circle, we know that governance and control of what is going on in society, policies and programs, cultural and societal norms, and societal priorities and values influence all of the things that are inside the circle. And many of those things are dictated by long-standing racist issues. Next slide. So if we look from a political perspective at women's health disparities, we see things like the U.S. Public Health Service syphilis experiment, which many people know as Tuskegee, but I prefer to call it by its official name so that people understand who perpetrated this very unscientific study of syphilis in Black men. The major issue is that women were not informed of their partner's risk or their infection status, which means they contracted syphilis and often passed it on to their infants while they were pregnant. There was a sterilization campaign on the island of Puerto Rico, which resulted in women being sterilized without their knowledge. Men were encouraged to bring their partners in and were paid to bring them in so that women were sterilized. Women ended up on the island of Puerto Rico with the highest sterilization rates of any place in the Western world. There are elevated rates of hysterectomies. Fannie Lou Hamer calls it the Mississippi appendectomy, but this was not unique to the South. In Boston, a bunch of medical students exposed a practice where Black women were used as practice subjects for residents in OBGYN to have hysterectomies. And as a practicing physician, I often noticed that women of a certain age who were Black all had had hysterectomies. We know that contraceptive testing has been disproportionately conducted among women of color. There was disproportionate prosecution of Black pregnant women with positive drug tests. They were penalized or even charged with unlawful conduct and imprisoned for things like delivering drugs to a fetus, even though Black women are no more likely to use drugs than white women. And we recently have seen, with increasing restrictions on abortion, criminalization of miscarriage, where women who are bleeding, who present for treatment, are accused of trying to abort a fetus and have been sentenced to jail sentences. This will likely get worse as more and more abortion restrictions occur and can lead to various pregnancy-related outcomes that could result in death because of the mismanagement of bleeding during pregnancy if women are reluctant to come in to be seen or they're mistreated. Next slide. When we look at the impact of racism on health. And this slide is a little bit hard to see, but I want to just point out that if you look at the years for the citations I give there, they date back to the 1990s. And we know that there is a biological impact of racism that affects both the nervous and endocrine systems, the immune system, metabolism, the cardiovascular system, and even people's body composition, which results in some of the issues that we're talking about in terms of cardiovascular disease, diabetes, high cholesterol, high blood pressure, and overall poor health and premature death. Next slide. When we look at the interpersonal and systemic barriers to high quality women-centered care for women, we know, as I already pointed out, that provider bias and disrespect is part of that. But we also know the health system has fragmented services for reproductive age women. There's uneven access to care because of financial barriers. There's maldistribution of appropriate providers, including OBGYNs, midwives, and primary care physicians. And there are gaps in the quality of care due to race and income and social factors. We also know that environmental factors increase exposure to toxins and to detrimental community factors such as food deserts and increased exposure to tobacco, for example. The COVID-19 pandemic exposed and worsened a lot of these factors, and I'll show some data that looks at what the impact of COVID might have had on maternal health outcomes. Next slide. When we look at the interpersonal bias that women experience, in some work that I did years ago, we interviewed Black women and their white physicians to try to get a sense of what type of factors were operating as they went into a doctor-patient interaction. And what we found is that women definitely have highlighted that their past experience, their race, and their gender were the most important factors that they considered when they thought about how they were going to be treated. And physicians had other factors that they considered. But these filters, as I call them, basically created assumptions both on the part of the doctor and the patient, and it influenced their behavior between each other. Next slide. Physicians admitted that they were concerned that they didn't have the right set of skills and knowledge to treat certain women, and they feared being exposed as being incompetent. They said that they advocate more readily for patients who they feel a connection to, and they code and label patients for expediency because they were under so much time pressure to get through quickly and keep moving. They don't discuss differences and they don't involve the patient, and they stereotype, and this is most likely to occur in a place where they're making decisions under pressure. You can understand this happening in a situation in the hospital where there's a maternal complication, for example. It also operates when there are limited resources, and we know that Black women who are in hospitals with limited resource, with a higher population of Black patients, have worse infant outcomes and worse pregnancy outcomes than Black women in other situations. Next slide. What we see on the patient's side when they experience bias is that they hold negative assumptions about providers. They interpret provider behavior from the baseline of mistrust. They withhold important information. They delay presentation for care, and they don't trust recommendations. Next. So the implications for maternal health, as I said, there's an increased prevalence of chronic conditions. There's lack of continuity of care. There's delayed presentation for preventive and ongoing care. And women are less likely to be healthy before, during, and after pregnancy. They have a higher likelihood of unintended pregnancy, and they have less access to high quality and competent providers. Next. So what does this mean if we look at maternal death trends? Well, as I said, if we look at this slide, back in the 2005 to 2007 period, there was already a disparity in maternal deaths. They were more than twice as high as for white women, which you see in the first bar on these slides, which is kind of an orange color. The brown bar represents Black deaths. If you look at, if we go up to 2018, you see that Black deaths increased to 37 per 100,000 live births, still more than twice what white women were experiencing. And it was, before and after around 2018 that a lot of attention was paid to the high rate of maternal deaths in the United States and the disproportionately high rates of death among Black women. But in 2019, that rate went up to 44 deaths per 100,000 births, and in 2020, with the onset of COVID, perhaps, it went up to 55. So we are definitely going in the wrong direction. The disparity between white and Black women has increased, even though the death rate among white women has also increased. And this is obviously not where we want to be at this point. Next slide. When we look at the timing and causes of pregnancy-related deaths, first of all, about a third occur during pregnancy. About a third occur during the first days after delivery, and then a third occur in the postpartum period. The dotted arrow on this line represents approximately when people are in hospital. The solid arrow represents when people lose their Medicaid coverage for as a woman after pregnancy, if they don't live in a state that has expanded Medicaid. If we look at the causes of death, medical conditions, which include things like diabetes, kidney disease, that sort of a thing, heart diseases, infections, and hemorrhage account for about 50% of the deaths, and about 70% of them are avoidable. We know that when hospitals make an effort to address issues such as hypertension and hemorrhage, that they can improve the death rates. And this has happened in California, where they've had a concerted effort to improve maternal mortality and morbidity by focusing on these conditions that cause the problem in the hospital. Next slide. So what do we need to do to eliminate disparities? Next. The biggest thing we need to do is give women access to the care they desired. On the left here, you'll see a quote from a woman who was interviewed by Kaiser Health News for an article that came out in 2020. She knew that she wanted to deliver her fourth child in the hospital. Her husband was a little bit skeptical she wanted to deliver her fourth child at home. Her husband was a little bit skeptical about the safety of that. But after COVID struck, he agreed that the hospital would be safest. And what this woman was articulating is that she wanted to have care that was women-centered. Women-centered care focuses on women's needs, addresses gender and racial bias in the delivery of care. In women-centered models of maternity care, they employ not only medical and non-medical personnel, but include women of color who support women during their pregnancy, labor, delivery, and postpartum. Next slide. So if we look at what are the types of outcomes that you see when you have women-centered models of care, first of all, if you look across at the top, it defines what some of those models are. Group appointments where women come in together for their prenatal care and postpartum visits and support each other. Team-based care where you have a team of providers assisting women through pregnancy and postpartum. That includes doctors, nurses, community workers, doulas, midwives, and having birth centers that are specialized places where women can give birth outside of a hospital have all been shown to improve outcomes, including making sure that women show up or have a way to get to their postpartum visits so that any ongoing issues that they have after giving birth are identified and addressed. They have increased breastfeeding, less postpartum depression because it's recognized and treated. They're more likely to get postpartum contraception if they want it, and to transition to primary care, have their social issues addressed, and to have fewer cesarean births if they have midwives or birth centers. Next slide. So I want to talk a little bit about the role of Medicaid. Next. This shows that for people who are non-elderly, the percentage of people on Medicaid is higher among Black individuals. You'll see here that Blacks make up 12.5% of the US population, but 20% of the Medicaid population. So they're disproportionately represented. So Medicaid is even more important for Blacks, and you'll see for Hispanics as well. But Medicaid is the single largest payer of maternity care in the United States and funds more than 40% of all births. Next slide. If you look at, remember I told you that some states chose not to expand Medicaid under the Affordable Care Act. This slide shows as of February 2022, which states adopted expanded Medicaid, the dark blue states. The orange states did not adopt Medicaid. And if we look at the next map, this shows the pregnancy-related death rates in the United States. And on this map, the darker the color, the higher the pregnancy-related death rate. And you'll see that there is a definite correlation among the states that did not adopt expanded Medicaid and those that have the highest pregnancy death rates. Next slide. So first of all, what can Medicaid do? Well, the fact that standard Medicaid only covers postpartum care for up to 6 weeks is not good health care for anyone. The American College of Obstetricians and Gynecologists have recommended that we expand the definition of postpartum care to not simply be a post-pregnancy check, but there should be a full scope of services and there should be a transition to ongoing care for women. Next slide. Medicaid, as I said, is the single most largest payer of pregnancy. And what we need is for Medicaid to provide and pay for care that represents the women-centered models that support high-quality care for Black women. So this means standard payment and access to doulas, midwives, birth centers, and group prenatal care, and home visiting, and the use of community supports. Next slide. The other thing Medicaid needs to do is ensure access to care that reverses the discrimination and disrespect that Black women report. And to do that, they really need to measure satisfaction, bias, and discrimination and act on what they're finding in terms of how they pay providers and how they support providers. So, as I said, if there's one thing I want you to leave from this presentation is that there are grave disparities in women's health, Black women's health, across the life cycle, but the various disparities that we see have an impact on women's ability to have healthy pregnancies and to have healthy outcomes from the pregnancies for themselves. And we need to develop better models of care, pay for them, and make sure that all women, regardless of their income or race, have access to those models of care. So I'm going to end here. I hope I have time for a question or two.
Thank you so much for that discussion, Dr. Bigby, and highlighting some of the racial disparities that kind of impact women's health today. I don't know if anyone in the audience, I think we have only time for maybe one question. If anyone in the audience has a question for Dr. Bigby.
So I see there's one question: how do we increase access to midwifery education for aspiring Black midwives? That is an excellent question, and I think there are a few things that need to be done. First of all, there needs to be more education for women so that they know, or actually, anyone who wants to be a midwife, but there needs to be more spread the word that midwives are a resource for Black women, not only for pregnancy, but for whole women's health, for reproductive age women. And we need to expose young women, young girls who are looking at health careers to this as an option. There needs to be financial support for this. I would argue that organizations that are providing scholarships or loan repayment for doctors who have gone through training to become OBGYNs or primary care physicians should be supporting those types of efforts for women who want to become midwives. And I think that we need to hear from midwives who are out there that they want more people to come into their field. And we need state laws that also support the practice of midwives around the United States, whether midwives can practice independently or need to be under a physician vary widely from state to state. The outcomes for women are just as good in states that don't require doctors to supervise midwives as they are in states that do. So there are things that definitely could be done.
Thank you for that answer. Unfortunately, we cannot take any more questions. Thank you again for that discussion. So next on our agenda, we're going to have a session with Dr. Rachel Hardiman, who's going to speak about racism's impact on Black birthing people. And this session can be found in the lobby under the agenda tab. Thank you again, Dr. Bigby.
Thank you.